And my name is Lise McDowell. I'm with Neurelis Pharmaceutical, and I have the pleasure of introducing Dr. Silva Colon out of Valley Children's, pediatric epileptologist, to speak about when medications fail, what's next.
So, hi everyone, I'm Dr. Silva Colon, and let's start the chat. So, firstly, mostly everyone is here is aware epilepsy is among the most common serious neurological conditions, and there's about 3.4 million people in the United States with active epilepsy, and about of those almost 500,000 are children between the ages between 0 and 17 years old. That gives us about 1.2% of the population in the United States. Of these, 39,000 of the adults can have epilepsy or seizures can be controlled by medications, and about 11,000 are children. That's about, we have 107 adults a day that are diagnosed with refractory epilepsy or drug-resistant epilepsy, and 30 children a day are having this condition or this problem. And this graph is a little hard to see from the distance, but mostly we start with the first medication that was ever created for treatment of seizures or epilepsy in 1853, and then we have the phenobarbital in the 1910s, and then we have a boom of new medications. They're called the first generation anti-seizure medications from the 1930s to almost 80s. Including the second generation, and then we have another boom in the 90s to now. This one is in 2012, so there's medication that probably you are not seeing there of the newer medications that are not there. And unfortunately, even with those all the medication that we have available, we still have what we call drug-resistant epilepsy. So what is that? So it's a epilepsy that you have to fail at least 2 well-chosen and well-used seizure medications to be called drug-resistant epilepsy. And that's about 40% of the patient, unfortunately. And then we know that being a drug-resistant epilepsy, is associated with loss of independence, there's depression, more neurological impairment, worse quality of life, and unfortunately mortality that can be due to sudden unexpected death in epilepsy, unfortunately accidents, and suicide. And a little bit more getting why I'm gonna talk about other options of apart from medication is because in this study that you can see here, this was carried out in between 1984 and 1997. They used a total of almost 600 patients, and this gives you how much of these patients were seizure-free, with just one medication. Then another 30% were free on 2 medications, another 4% in 3, and then we got a 36% of patients that are not seizure-free even with 3 or more medications. And this same study was repeated again in 2017, included patients from 82 to 2012, and we mostly have the same kind of percentage. Then that's what brings me to other options apart from medications. So talking about epilepsy surgery, that we have seen results at 60% seizure freedom in patients that are not drug-resistant epilepsy. There's receptive surgical treatment. There's also neurostimulation. I'm gonna talk more in depth as the presentation goes. That we have the vagus nerve stimulation, or VNS. We have the responsive neurostimulator, or RNS, and deep brain stimulation, DBS. And other less invasive surgeries that not as invasive as resective, laser interdistant thermal therapy and stereotactic radiosurgery that are newer. And then why epilepsy is under use. So in my case, I don't know if you know their experience, some patients, even doctors don't even know that surgery is an option for epilepsy. And there's about 1% of candidates that can be eligible for surgery that are not referred or less referred. And most of the cases we have barriers, so it's either access to the centers, to the epilepsy centers, lack of having an epilepsy program where they live, transportation, the insurance, or inability to actually the parents or the patient to be able to get the process that are gonna talk in detail what the progress of an epilepsy surgery means. And yes, there's also negative attitudes toward or fear of surgery. And this is, I think, the major one is the lack of general education or acknowledgement of among even doctors that their surgery is an option or could be an option. So what makes a patient a candidate for epilepsy surgery? So it has to be a debilitating seizures that can significant impairment of quality of life, and have to have failed at least 2 well-tolerated, well-chosen anti-seizure medications. And then also these could be patients that were seizure-free medication and they unfortunately stopped doing so, or patients that have remission after that too. So what are the pre-surgical evaluation goals? So it's establish if this patient is a patient that could be a surgical candidate. Then we can identify the epilepsy type and localization, meaning the focal epileptic zone, so where the seizure originates, and then the epileptic zone is where we can define how the minimum amount that we need of the cortex that we need to reset to produce seizure freedom. And this is a gram how the pre-surgical evaluation decision tree goes. I don't know if you can see it from where you are, but mostly we have a drug-resistant candidate or epilepsy patient, and we go first with the pre-surgical workup. That will include a brain MRI, a video EEG that will capture ictal and interictal. I'm gonna go in by phase later on, and neuropsychology testing, and in all cases it's a multidisciplinary team that meets and get all the information. So there will be neurology, they're gonna be the neurosurgeons, the neuropsychologists. So we have social workers that were included. It's a big team that we put everything together because it's an extensive process, and also we have to consider the benefits and risks of going forward. And at any step of the way, we always are taking the patient with the consideration. If we are where we stop or we continue. And then when we have this evaluation, we decide is a focal epilepsy, is this a multifocal epilepsy, or do we have a generalized epilepsy? With generalized epilepsy, we have options. So mostly it will be a neurostimulation that I'm gonna go more in detail later. Multifocal, we can either neuromodulation, and some could be go for resection. And for focal epilepsy, there's another process. So if we have an MRI lesion point that correlates with the information that we have in the EEG, that patient could be candidate for epilepsy surgery or resective. That could be a lobectomy, so a part of the brain. It could be a lesion, the part of the lesion that we remove only, and also there's laser ablation. If the MRI is negative or doesn't correlate with the information we have from the video EEG, then we do further testing that I'm gonna go in day later. And then there's another phase to decide if he will be a candidate for resective surgery or a neurostimulation therapy. So this is a little chart more bigger of the same graph that I showed before. So the phase 1, we divide it in phase 1 and phase 2. The first 3 are the ones that I was speaking about, the surface video EEG, meaning that it's called EEG, that everyone knows. The MRI and the neurophysical testing. Those are the first 3. If information this is enough, it could be enough. We don't have to go further testing. But sometimes we need further evaluation. That's when the functional MRI, and not all have to be done, but this option that we need to look more. And then we have the phase 2. I'm gonna go in detail. All right. So video EEG or video electroencephalogram. So I don't know if everyone is familiar with video EEGs, but it's not a 30-minute study. It could be between 3 to 5 days, sometimes longer. And what we want is to analyze the patient's electroactivity ictally and interictal, meaning ictal means actually capturing seizures even, or ictal events, and interictal means that between seizures, how the brain looks between seizures. They will help to confirm the diagnosis, because mostly when you come to the office, you have seen the seizure and you tell us how the seizure looked like, and we may say, okay, this looks like a focal seizure, no, this might be generalized, but here we actually capture the seizure. We also have the electric activity. We can give you a more detailed confirmation of the diagnosis of what type of epilepsy you have. And also we can pinpoint where the seizure is coming from. And then also we will help also see if there's medication non-compliance. If we have pseudo-resistant, meaning that unfortunately we have patients with non-epileptic seizures, and also we have patients that are putting a wrong medication for their type of seizures. If you have questions in between, also free to ask. Then we have the brain MRI for investigation. So it's a high-resolution dedicated study. And sometimes when we come for evaluation for surgeries, the patient already have a brain MRI, but sometimes we need to get a new one because maybe it's an old one, or it wasn't done with a specific imaging technique that we need for evaluation for epilepsy surgery. So that's why it has to be dedicated for the epilepsy protocol. And we also wanted for our expert neurology radiologists to read it, to better sensitivity of it. In some cases, the MRI is read as normal, when it's read by a special dedicated neuroradiologist that is specialized in epilepsy, he can find something. So it's important. The other thing is the neuropsychology testing that will help. It's really helpful, and also it's necessary to understand the patient, cognitively and motor, if any delays. And then also they can also help with the word in the brain is the seizure is coming, because of what delays they have, they can also localize the lesion as well. And also will help predict any cognitive outcome after surgery if we go to receptive surgery. And this is a little picture of different neuroimaging. This is an X-ray. Mostly we don't see the brain there, so it doesn't helpful. Then the CT scan, or the assisted scan here. As you can see, for me, when I explain the CT scan, I say that it's like a picture of the brain, like a sketch of the brain, and then the brain MRI is more a photograph of the brain, so it's more detailed. And then the MRA here is an angiogram, meaning that what we see is the vessels of the brain. And then we have a PET scan that is a more specialized study, that we can see how the brain metabolizes, and how the oxygen and glucose actually is on the brain. It also helps later, I would say, with where the seizure is coming from. Okay, so again, the PET scan is a positron emission tomography, and it's SPEC. So the PET can be done interictal, and the SPEC is ictal, meaning that PET we see different kind of modalities if we capture between seizures the brain, and the SPEC another kind of imaging or difference, because we capture when the brain in the seizure. So in the PET or interictal, in between seizures, the region of the brain that is having the seizure have hypometabolism, meaning that it's not well receiving the nutrients that it's supposed to be in because it's a affected area. And if we capture the imaging during the seizure itself, because the activity on the brain is ceasing or having the non-activity, we see increase of perfusion. And this is a little example of it. So in the red is more active, as the colors go in a more green and blue is less active of the brain, and we see the same area on the brain when it's in between seizures. That is, you see that it's supposed to be red, like all the cortex, but here is green, it's supposed to be red. And during the seizure, it's red because it's activated because of the seizure. And then in functional MRI, it will be helpful to lateralize where the language center is on the brain. Normally it's on the left side, but other people, depending on the epilepsy, sometimes they lateralize to the other side. So it will be helpful if we need to be closer to that area, if we would be affecting language or no. Also motor and sensory. And then the magnetoencephalography is another tool that we use to understand better where the seizure is coming from, and it's non-invasive. In the PET scan, we actually need to do a specific. So we need to do an IV for a specific contrast to help with the metabolizing part. That makes we don't have to do anything invasive. And it's also a magnet. They use MRI, and what it do help because it's capture the electricity on the brain, and the normal electricity you can point better where the abnormal activity is coming from. And the last sentence that is not useful to patients that have rare discharges. There's patients that have poor interictal activity, also in between seizures they don't have that too much activity. So those patients this will not be a good study for them. And that's why we do the first one of the study we do is the video EEG, the scalp EEG. And again, so that's the phase one, everything I talked so far. We can only do the first three, but if we need more information, because the information of these first three were not consistent with one another, then we don't have to do everything. We pinpoint, depending on the information that we have, what would be helpful for us to get more information on where we're supposed to go. And if we don't have enough information or everything is contradictory, that's when we start phase two. And phase two, it's because we need more information. We didn't have, either the study didn't match, or we have doubt where the epidemic zone or where the seizure onset zone is with the information that we collected in phase one. Or we have a poorly localized lesion with the borders. We have more than one lesion. There was a prior history of surgical failure, or where the seizure is originating we are near the language area. So there's phase two is what we call the intracranial video EEG monitoring, and that will again help. We're gonna record seizures and between seizures to see where the actual epileptic zone is coming from, the seizure is coming from. And also will help localize the language, if the language is affecting during the seizure. And also we can actually stimulate and do mapping. So we know when we map, we know that we're gonna affect any motor or language area or sensory area as well. And then there's two approaches to intracranial EEG. So it could be acronectomy, so removing the bone and going directly to the brain to do either subdural electrodes, grips, and strips. So this is a grip. This is not actual brain, but that's how we place them. And there's the stereo EEG, that is depth electrodes. So we place electrodes doing a little tiny hole in the cranium, on the skull, and go directly to the area that we need to record. And sometimes we have the combination of both. And if the person is not a candidate for resective surgery, we have other options. We have the responsive neurostimulation, or RNS. We have the vagus nerve stimulation, or VNS. And these are newer, is the deep brain stimulation, or DBS. So these here, you can see? No, you cannot see. This is the RNS, this is the VNS, and this is the DBS. Then the RNS, or responsive neurostimulation system, is a device, a medical device that doesn't require a removal or resection of the brain, and it's an implanted device that we can record, and we can also send signals to stop the seizure, like a pacemaker, kind of. So it's a closed loop. So with this device, we can, apart from sending signals to stop the seizure, or electricity to stop the seizure, we can also record seizure, the brain activity at the same time, like an EEG, but it's a single lead to the area that we are interested, or we know this area where the seizures are coming from. You can download it yourself. That's why we see that person here with the little one, or a little, we call it one, little thing too, that they will help transmit the information of the device to the computer. And when you teach the device as well. So when we identify the normal seizure pattern, or the normal activity pattern that goes to a seizure, we teach the device to send the activity to it to stop it. The other device is with RNS, we have a 16% seizure reductions in patients that have frontal or parietal seizures, 58% in temporal onset, and 51% in multilobar onsets. With VNS, is also a 1 to 2 hour surgery. We put the generator on the left side of the chest, and there's a cable that goes to the vagus nerve here in the neck. So there will be 2 incisions, one here and one in the chest. And mostly this one indicated for generalized or multifocal type of, or mixed epilepsies. This is an open loop, meaning that we cannot read anything from it, but it will send a continuous loop with sending the neurostimulation to control seizures, and we also can send a signal additionally we feel the seizure is coming to. And with this one, there's a greater than 50% seizure reduction in some patients, and others it's between 23 to 73%. And when I told you that you can send when you sense the seizure coming, you can swipe the magnet to give an extra electric charge to stop the seizure. And a little bit of information about it, you can also turn it off by putting the magnet on the device, on the where the device is. And as soon as you take it off, it will about 30 to 30 seconds. It can start again and do it. This also can detect seizures because of the heart rate, and we can tweet it or do the recordings to help the patient needs. And the deep brain stimulation is also an open loop, so meaning that we cannot read from it, but it will send continuous impulse or electricity to control seizures. This one is mostly reserved for poorly localized seizures onset zones, multifocal and generalized epilepsies at the VNS. It's 29 to 57% seizure reduction. It's one of the newer devices for seizure control. And it's still mostly approved in adults. We're hoping that it will be later for pediatric population as well. And what's the benefits of epilepsy surgery? So we have significant improvement of quality of life because we have seizure reduction or freedom, and also help with the cognition. It doesn't decline them with mood or neuropsychology functions, and as because seizures are controlled, we have decreased in morbidity and mortality. And some patients are better controlled, are even seizure-free when even if they start taking the medications, because they are now better controlled. And some patients actually we can wean them off of medication and complete seizure freedom, depending on the case pattern. And the other thing that I didn't mention is that option, because mostly the presentation they get it for epilepsy surgery. The other options are ketogenic diet. Any questions? Okay. So here in Valley Children, we have an epilepsy support group program that we have interactive videos on how to use the rescue medications that are prescribed by your doctor. And we have videos for either lorazepam, can I say the names? Lorazepam, Valtoco, Diastat, and Niacinamide. And if you are interested in seeing these videos, you only have to take a picture or scan that code, and you can have that available for you. Reference, and there's my reference. Any questions? And if any further question for our epilepsy support group, you can contact our epilepsy program manager, social worker Kaylin, that is here in the front. That's all for today.